we will be contributing tissue to that project. We're also, of course, interested in using the same sort of techniques to look at genetic and epigenetic profiles in epilepsy patients, and we're also involved in some cross-country collaborations with Diane Langford at Temple University in an effort to look at molecular markers for seizures. Ted had mentioned, Dr. Berger had mentioned this project, which is a project that Dr. Heck, Dr. Berger, and myself began to engage in. And I'll speak a little bit more about this in just a few minutes. So the role of the neurosurgeon in this entire effort, in this continuum, is that we do have access to the normal human brain. Neurosurgeons have access to the brain, but only epilepsy surgeons have access to quote-unquote normal, right? Human brain, there's no tumor there. And in fact, when it comes time to actually deliver the device to the brain, I think that we have to be very much involved in the design of the actual interface and delivery. One other way that we feel like we can contribute is in this whole concept of correlated neuroscience. And what does that mean? Lots of different ways to study the nervous system, whether it's fMRI or electrophysiology and so on and so forth. But and of course, this project is a project that was brought over to Rancho by David Millett, who's one of my colleagues here at Rancho, principally here at Rancho, looking at fMRI and connectivity and complexity in the neural networks as a metaphor for locating areas where disruptions can be related to seizure localization. But ultimately, all of these ways of studying the nervous system in the brain has to be brought back to what we consider to be the gold standard, and certainly in epilepsy, it's direct electrophotography of the brain. So I'm going to spend just the next couple of minutes to talk about what it is we're trying to do here with all of this, right? We're not involved in the science of it, right? We like to contribute to the scientific enterprise and the ideas. We also like to take care of people, right? And that is our principal primary responsibility. I think that there's a chore associated with our task. It is a pleasure, but also a chore. It's the care of our patients who are ill. But how do you take an idea or discovery and make it a useful tool? And Kent has back there in mind, you guys live in the DC area, and I was recently in DC. And every time I'm in DC, I try to go to a museum because I think museums are wonderful places. It's where we put things that we're proud of, right? We don't put things we're not proud of in museums. We put things that we're proud of in museums. And I recently had the opportunity to visit the National Air and Space Museum. I think most of us recognize this imagery that Icarus, right? He was kept as a prisoner in Crete, and his father, Daedalus, who was a master craftsman, crafted a set of wings made out of wax and feathers for him to escape, with the warning that he shouldn't fly too close to the sun, knowing the wax would melt and he would fall into the ocean and drown. I assure you that is not how man flew, right? To get from looking into the sky and seeing a bird fly to actually get in an airplane, it took something more like this, right? So this is a room that's dedicated to the Wright brothers. What you see here is the original, and this is the original 1903 flyer. But more importantly than this flyer, if you actually spend a little bit of time in the room and do more than take a photograph, you see all the other things back here. What these are gliders and controls of the flaps and rudders of actually how to safely fly the plane. And so after years of experimentation, they finally took to the skies in 1903, December 21. Shortly thereafter, and I just want to run through, I love airplanes, so if you bear with me. So of course in the First World War you had SPADs, right, and albatrosses, and phalluses, right? So by 1927, Charles Lindbergh flew across the Atlantic Ocean. So 1903 was the first part flight, and 24 years later, somebody flew across the Atlantic. Something we take for granted now, but it was you might as well go to the moon back in 1927. Into the Second World War, this is of course 1930s, 1940s, you had the Spitfires and the Hurricanes, the Battle of Britain, at the Messerschmitt 109, the infamous, right? The Mitsubishi A6N50. Of course, the Focke-Wulf, its only radial engine plane, fighter plane in World War II. Of course, the great American planes, the P-51 Mustangs and the P-40 Warhawk, Kitty Hawk, Tomahawk, whichever model you wanted to pick. Of course, the P-38, the wonderful P-38 Lightning. Of course, the great naval fighter aircraft, the Corsair, Hellcat. And then the game changer, the Messerschmitt 262, which is the first jet fighter plane. Very shortly thereafter, by the 1960s, you had the aircraft that was being famous by Tom Cruise and Top Gun, which is of course the F-14 Tomcat, and the XF-35 prototype for the current stealth-capable fighter planes of the Navy and the Air Force. And I think even in this arena, you see the potential benefit of taking human beings out of harm's way in the defense of our country. But if you would have told the Wright brothers that when they flew their plane that human beings were going to walk on the moon, they would have looked at you like you were crazy. Even they would have looked at you like you were crazy, right? And yet, the space shuttle is now in a museum, right? The program is over, and it's in a museum. And so it wasn't that long from 1903 to now, right? And all of those lessons come back to this image, right? December 21 in 1903, when they first got the plane off the ground. So at this point, I'd like to ask the audience if you guys know which one of the two Wright brothers flew first.
Wilbur.
That's right. Wilbur flew first. And everything we do is multidisciplinary, right? So the point is that I don't think anybody really cares, right, who actually got on the plane and flew. It turns out that they flipped a coin, the two brothers. They flipped a coin. And Orville won the coin toss, but he couldn't get the plane off the ground. So Wilbur, on his attempt, actually got the plane off the ground. So how is this relevant to us, right? So what we're interested in doing is taking scientific science, scientific discovery, all the things that you're going to hear about tomorrow, that Dr. Berger was talking to us about, and what Dr. Anderson and all the other speakers are going to talk to us about tomorrow, and how we're going to take these scientific ideas and make them useful tools for our treatment of patients. So I think you need places like Rancho, right? Because these are where these patients are. And there are really two categories of patients, and each one of these can be very different in terms of what your approach is. The first kind of patient would be somebody who suffered a catastrophic injury, who really has much to gain and little to lose. And this would be the kind of patient that would be relevant to the program, the studies that Dr. Anderson and we're involved in. These are patients who are young with spinal cord injuries, who have no real prospects to expanding their world, and are therefore willing to participate in trials and studies such as the one that we're talking about tomorrow. But the second group might be a little bit harder, right? And when you think about the technology that Dr. Berger just described, where patients have relatively milder impairment, right? Where there's much to gain, clearly, right? But also much to lose. And you can imagine not just the remind patients, but patients, for example, who have incomplete spinal cord injury, who have significant disability, right? Who'd like to get a little bit better than that. How do you get these patients? How do you get these types of technologies into human beings? So I think you do it on the backs of taking care of patients. Let's just spend a few minutes and think about what this means. So Dr. Heck and I take care of epilepsy patients. So one of the paradigms for the future treatment of epilepsy patients is neurostimulation and neuromodulation. And of course, this is the vagus nerve stimulator device that's widely used, routinely used in our clinical practice to take care of epilepsy patients. So moving forward from vagus nerve stimulation, there are more advanced stimulation strategies, such as deep brain stimulation of the anterior nucleus of the thalamus, trigeminal neurostimulation, And of course, the NeuroPace device that was featured on the national media this afternoon with Dr. Heck. And the way NeuroPace works is it works like a defibrillator in the brain. There's a device, an electrode, that records seizure activity, and then a stimulation current is used to abort the seizures. So that approach is sort of like the neutron bomb approach, and Dr. Heck and Dr. Berger and I began to talk about ways of refining this approach, and of course that requires an interdisciplinary collaboration between all of us. And the idea is to, again, like my contribution, the section of the en bloc hippocampus that then we can slice in 50 micrometer slices and bring over alive to the main campus, where our collaborators in the Berger lab do the electrophysiology using microelectrode arrays. And we can induce the seizures in the slices. We can begin to identify subregions within the hippocampal architecture where the abnormally active neuronal populations lie. So we've seen that in the dentate gyrus, the CA1, in the subiculum. And here's an image that I think is really amazing, because what you see here is the five points on this electrode array firing in unbelievable symphony, and also different patterns being recorded in different regions within the hippocampal architecture. So how do you bring a technology, and I use Remind because that's something I'm familiar with, that we're working on, and that I've laid awake nights thinking about how you can actually get this into human beings safely. So here's a roadmap that might actually work, right? It's certainly plausible, and we think possible, and hopefully very likely, is that we understand that epilepsy is the most common neurological disorders worldwide, and many adult patients have mesial temporal sclerosis and therefore have hippocampal dysfunction. And if neurostimulation is increasingly important as a treatment paradigm for this disease, and future developments in this neurostimulation paradigm involve the development of microelectrode arrays to apply stimulation current to specific subfields of the hippocampus. Now we have a reason to actually design microelectrode arrays that will be placed within these subfields and possibly used as a platform for bringing realization to some of the concepts that Dr. Berger has described. But the key, in this case, where patients don't have a catastrophic injury and they do have a lot to lose, is that you do this step by step by adding no additional risk to the patient in the treatment of their normal disease. And that might be a way that this can actually happen. So, what are we doing with restorative neurosurgery here at USC? Future directions, right? The idea is to create this living laboratory for which all of these wonderful scientific discoveries can be safely brought into human patients. We're not giving up on biological strategies. We're part of Eileen Anderson and Nobuko Ichida's disease team, where this is a large grant funded by the California Institute of Regenerative Medicine, looking at using stem cell therapy for patients with incomplete cervical spinal cord injury. And it's a 5-year grant, and the goal at the end of 5 years is to move into humans again. And I think that we're absolutely delighted to position ourselves and Rancho Los Amigos for all the reasons that this collaboration with Dr. Anderson is really productive, and this collaboration with Dr. Berger as well. Now it's really interesting, right? So far we talked about, movement and cognitive memory and so on. Where it gets really interesting when you talk about the higher order function. We had with my mentor Michael Puzzle considered the concept of psychosurgery, and psychosurgery's got a really bad name, but I'll tell you that Antonio Gasmoniz, who developed the frontal disconnection, in other words, the frontal lobotomy, right? He actually won the Nobel Prize because before he invented that technique, there was no psychotropic medications, and the only way that anybody could treat these poor paranoid, violent, schizophrenic patients was a straitjacket and padded room and ball gag in their mouths, right? So his prefrontal leucectomies, the frontal disconnection operation, in fact, was extremely important and helped thousands of patients in the world. And there's no reason why this type of strategy, surgical strategy, and I will tell you that we do frontal disconnections all the time, pharmacologically, right? We give people Haldol, we give them psychotropic medications, and really there's no difference. Is that true? This is really just a laundry list of the potential diseases, and I really love seeing the obesity down here at number 5. I think that if we could get everybody to lose 30 pounds in our country, and we would eliminate at least 50% of the healthcare costs associated with our population, right? And some of the enabling technologies that's going to allow us to really begin to engage in future surgery of the mind and mood. So 2 years ago, when Dr. Raisin first came to Rancho, she came up to me and asked, "Do you do any brain-machine interface research?" And I said, "No, but we can," right? And I meant it, and I think the reason I felt that we could was because we are here in Los Angeles. We have this great patient population. We live in a city whose contribution to the world is creativity, right? We have no statues here in LA. Everywhere you look on the East Coast is a statue, a bust, a painting of some guy that you'd have to look down and remember his name. But here in LA, we don't have any of that, right? We are really looking forward to the future. You make a movie, 2 years later, somebody's going to do it again and not even give you credit. And we live in an environment where some of the greatest scientists live, and you hear talks by many of these scientists tomorrow. And some of the technologies involved in the science can be applied to taking care of human beings and, in essence, creating replacement parts of human beings. And that, of course, is what I was interested in doing since I was a child. So this is what the restorative surgery landscape looks like to us, and each one of our collaborators can put themselves in the middle, and I assure you that there are images where that is the case, but since I'm giving the talk, we're talking about restorative clinical neuroscience. What do you need to do this? You need science, right? You need really great scientists, and I think that we are certainly fortunate to have established relationships and collaborations, really productive collaborations with some of the great scientific minds in the world at Caltech and the Detroit School. You need outstanding acute care hospitals, and I think that the capabilities provided by the Keck Hospital at USC and LA County USC Medical Center is at least as good, if not better, than anywhere you find in the world. And lastly, and since we're standing here at Rancho Los Amigos, since the Technology Summit is here at Rancho, you need a rehabilitation hospital, because this is where patients find their home. This is where we take care of such patients. And if you give a disabled patient a technology or new capability, you have not, in fact, cured them of their disability. What you've done is given them a new tool, and somebody has to teach them how to use this tool. And these same people have to teach the patient how to integrate this new tool into their disabled environment. And in essence, this is what we're trying to do here at Rancho Los Amigos. We'll talk about team members, and to talk about all the people involved in all of this work would truly be beyond the scope of this talk. And this, of course, is the primary group that's involved in the epilepsy, comprehensive epilepsy program. And it seems like every year we do a group picture, it gets larger and larger. And I think there's been a few more added since this picture was taken last year. But it represents about 50 people spread out over all the institutions that we're talking about.